Welcome to NephroTube Nephrology online lectures. In this lecture, we will discuss the acute management of acute hyperkalemia. All NephroTube PowerPoint lectures are available at nephrotube.com, and the recordings of previous lectures and online webinars are available on our YouTube channel, NephroTube, in both Arabic and English languages. We are posting daily MCQs and online exams on our Facebook groups. Regarding hyperkalemia, why hyperkalemia is dangerous? At first, we have to say that chronic hyperkalemic patients may tolerate hyperkalemia. CKD patients and end-stage renal disease patients may tolerate hyperkalemia because it may occur gradually. However, in acute hyperkalemia, as our talk now, acute hyperkalemia and acute kidney injury is much less likely to be tolerated because it occurs in acute onset. Especially if the patient is oliguric anuric or if the patient is of the elderly age or if the patient has cardiac disease. Yes, there may be a hemolysis artifact hyperkalemia because of the lab error or because of the hemolysis of the red blood cells in the test tube, but treatment shouldn't be delayed of hyperkalemia. You have to put the patient on a cardiac monitor and start the treatment if there is cardiac changes on the ECG, till repeating the test of the potassium. So the most important clinical presentation and the most dangerous clinical presentation of hyperkalemia is the ECG changes and the cardiac toxicity, because potassium mainly affect the cardiac action potential, both the slow action potential of the SA node and the fast action potential of the cardiac muscle. But we have to put in mind that mild ECG changes can progress to life-threatening disturbances very quickly. So if your patient has a mild ECG changes, don't be calm regarding the treatment of hyperkalemia. You have to treat him as those with severe ECG changes. Also, normal ECG doesn't rule out any cardiac instability. So if you have a patient with hyperkalemia, although of the absence of ECG changes, you have to emergently treat this hyperkalemia. Some other factors that may coexist with the patient and affect the ECG and exacerbate the condition as coexisting hypocalcemia and acidosis according to the etiology of the acute. What are the ECG changes that I can see in patients with acute hyperkalemia? The first and most famous change in ECG is the peak DT wave or the tenting of the T wave. Actually, potassium is important for the repolarization of the cardiac muscle. And the T wave in the ECG represents the fast repolarization of the cardiac muscle. So it may be the first wave to be affected. Second ECG change that we can see in cases of hyperkalemia is loss of P wave. Then we can see widening of the QRS. Then we can see the sine wave with deepening and widening of the S wave. And finally, we can see ventricular fibrillation, asystolic cardiac arrest. Any of these signs in a hyperkalemic patient, especially with severe hyperkalemia, is important to start emergency treatment. Okay, what are the treatment steps? I start by point 2 and 3 because they are the emergent steps. Point 1, stop potassium intake. This will be the next point after stabilizing the patient. So to treat hyperkalemia, we have two main issues or ideas. The first issue or idea is the redistribution of sodium. of potassium, the redistribution of potassium. We try to shift the plasma potassium into the cells, to decrease the serum potassium level. But this will decrease the plasma level, but will not decrease the overall body content of potassium. So we must have another line which will help us to facilitate or increase the loss of potassium from the body through either gastrointestinal tract or kidneys. So the two main items in the treatment are the redistribution of potassium into the cells and the loss of potassium from the body. Let's start by how to redistribute potassium and how we can shift potassium into cells. We have three main drugs that facilitate the redistribution of potassium and cause the entry of potassium inside the cells. These medications are insulin with glucose, bicarbonate, and beta-2 agonist. Regarding insulin with glucose, insulin causes the shift of potassium into the cells by activation of the sodium-potassium pump and decrease plasma potassium level while increasing intracellular potassium level. Yes, we give 10 to 15 international units of soluble insulin in about 50 ml of 30% of glucose to prevent hypoglycemia over 10 minutes. It is important to know when this mechanism of treatment will act and for how long. So that will make me know when to repeat this method of management. The effect of insulin infusion with glucose on hyperkalemia starts to appear within 15 to 30 minutes, and its peak is about 60 minutes. And its action lasts for about 2 to 4 hours. So I can repeat this measure every 4 hours. Let's concentrate on that. Its action is not immediate action. Its action starts within about an average of 20 minutes, and its peak in about 60 minutes, 1 hour. Regarding beta-2 agonist, nebulizers of beta-2 agonist usually enter potassium into the cell by the same mechanism of action of insulin, by activation of the sodium-potassium pump. There are some debates about the use of inhaled beta-2 agonist in the management of hyperkalemia. The first debate that it acts via the same sodium-potassium ATPase action of the insulin, even it has a slower onset of action than insulin. And also, beta-2 agonists may precipitate angina and arrhythmia in a patient who is already at risk of arrhythmia because of hyperkalemia, and especially if the patient has underlying cardiac disease. So it may precipitate more arrhythmias and more lactic acidosis, worsening acidosis, and more hyperkalemia. So there is a debate about the use of beta-2 agonists in hyperkalemic patients, and it may be avoided, yes, but theoretically, it may be avoided to be used, but theoretically, yes, it has a theoretical effect and a clinical effect on serum potassium, but it has a slow onset of action, and it may precipitate cardiac arrhythmia. Regarding alkalemia, regarding the use of bicarbonate in the management of hyperkalemia, correction of acidosis mainly correct hyperkalemia, because acidosis in itself causes hyperkalemia. So we use mainly isotonic sodium bicarbonate solutions. We infuse it about 200 to 500 ml over 15 to 16 minutes. And the action, again, is within hours, not minutes. Very important caution point regarding the infusion of sodium bicarbonate, not only related in cases of hyperkalemia, but related to sodium bicarbonate infusion in any clinical situation, that try to not infuse it bicarbonate solution in the same cannula as calcium gluconate carbonate. We will use calcium in the management of hyperkalemia in a way that we will say later in our lecture, but don't infuse it bicarbonate in the same line as calcium to avoid its precipitation unless thoroughly flushed, unless the cannula is thoroughly flushed with saline. And again, the care, because rapid correction of acidosis may precipitate hypocalcemia. This point, we discussed it in details in our previous lectures, the volume assessment lecture and sepsis in acute kidney injury lecture. We discussed in later the use of bicarbonate, how and when. Okay, so we discuss now how to redistribute potassium into the cell. So how to remove potassium from the body? We can remove potassium from the body by 3 ways. The first line is through GIT, the third is through kidneys, and finally through dialysis. Regarding removal of potassium from the gastrointestinal system, we use what is called the cation exchange resin. It is usually a drug in the form of powder. This powder contains a cation exchange resin. In this scenario that I am showing it to you, the cation exchange resin is sodium. The powder is containing a lot of sodium, while this resin is going through the luminal tract of the GIT. The sodium exchanged with potassium from the wall of the GIT, and then the powder with the potassium going out through the stool and decreasing the volume of potassium in the body. So by this way, there is an exchange between a resin inside this powder and the potassium in the mucosal wall of the gastrointestinal tract, with excretion of the potassium outside the body. Different type of resins for exchanging with potassium are available. The most common of them, the first two discovered resins are calcium sulfonate resin, calcium resonium, or sodium sulfonate. This resin cation exchange containing calcium and is containing sodium to exchange with potassium. They can be given either orally or rectally as an enema. If we give it orally, we give about 15 grams orally. Supplies the powder to be suspended in water. You can give it up to 4 times per day. Or you can give it rectally in the form of 15 to 30 grams suspended in 2% methyl cellulose and 100 ml water rectally up to 4 times per day. But it is important to know that this must be a retained enema. Every time you have to retain the enema for at least 2 hours, better to be more than 4 hours. So it may be more suitable in patients in ICU. And the most important, especially for the retained enema, that it may require saline irrigation through a catheter to remove the resin from the colon. Because as I will say now, that one of the most common side effects, or one of the documented side effects of these resins, especially sodium-containing resins, are colonic ulceration and necrosis. So it may be important to saline irrigation, it may require saline irrigation to remove extra resin in the colon. What are the side effects of these resins? The first of all is constipation. It may cause constipation, and constipation itself may cause paradoxically prevention of the potassium loss, because constipation will decrease the transit time in the colon with reabsorption again of the potassium in the resin. So it may be logic to give laxatives with these agents as lactulose, because giving laxatives may be more efficacious than the agent itself by preventing its constipating effect and facilitate the ongoing loss of potassium. The action of this medication is usually seen within 1 to 2 days, so it has a slow onset of action. As I said, one of the documented side effects of these medications, especially the sodium-containing resin, that it may cause colonic ulceration and necrosis, especially if it was used especially if it is used with sorbitol as a hyperosmotic laxative. And there is documented post-operative patients with ileus are at high risk. So the risk of ulceration and necrosis is more common with patients with ileus and patients with slow transit intestinal time. There are other resoniums rather than the calcium sulfonate, calcium resonium, and the sodium sulfonate, one which is called sodium zirconium. It exchanges potassium for hydrogen and sodium. And there is another sodium-free potassium binding polymer called batyromer that can be used to exchange intestinal mucosal potassium. Finally, we can remove potassium from the body through the kidneys by using of diuretics. And we discussed in details before the use of diuretics in our lecture of acute kidney injury volume assessment. You'll find it in details, the video and the PowerPoint on NephroTube. You can use furosemide in a dose of 40 to 120 milligram IV as a bolus, or as a slow infusion of 10 to 40 milligram per hour to a maximum of 1000 milligram per day. Last treatment line, if there is no response to all what I mentioned, you can use dialysis, especially if the patient is oliguric and anuric. Yes, it must be, or better to be hemodialysis, because peritoneal dialysis rarely indicated because of its coaction. Be sure that your patient is clinically stable, so you can transfer it to your hemodialysis unit. Dialysis usually remove, if hemodialysis can process about 20 to 60 liters of blood against a dialysate potassium of 1 to 2 millimole per liter, it is better to use low dialysate sodium, low dialysate potassium to correct this hyperkalemia, but take care of rebound hyperkalemia that may occur after dialysis because of the redistribution of potassium from intracellular compartment to extracellular compartment. So hyperkalemic patients with normal potassium level after dialysis must be admitted in the hospital with monitoring and the follow-up of the potassium level to treat rebound hyperkalemia if it appears. First line treatment. This is not a wrong slide. The first line of management that I have to do in cases of hyperkalemia, I didn't mention it at the start of the presentation. I intended to mention it later now to highlight that it is the most important line of treatment in cases of hyperkalemia, which is calcium supplementation. As we said, the potassium usually affects heart and causes arrhythmias, which is the most important fatal problem in patients with hyperkalemia. So I want to stabilize the heart back. The ion that will antagonize potassium effect on the heart is the calcium. So we give calcium because calcium is cardioprotective, not because calcium decreases sodium. Calcium doesn't decrease sodium. The main idea of giving calcium to the patient is to antagonize the potassium effect on the heart. So it is the first line of management in patients with hyperkalemia to stabilize the heart till you make your other measures to decrease potassium level. How we can give calcium? You can give calcium gluconate or calcium chloride in these doses. Give any of them over 2 to 5 minutes and repeat ECG after 5 minutes. If there is no improvement, you can repeat this dose and then make another ECG after 5 minutes. If no response, repeat your calcium dose. Maximum dose you can give is 40 ml calcium gluconate, which is about 4 ampoules. If no response, usually your patient need ICU admission and usually other measures to protect his heart, up to temporary pacemaker. The action of calcium acts within a minute, but protective effect lasts less than 1 hour. And this is a good window to give time for other measures that we mentioned to take its action, as insulin glucose, which acts usually within 15 to 30 minutes, and its peak reaches in about 60 minutes. Take care that calcium infusion may induce digitalis toxicity. So if in your patient history there is a digitalis medication, it's better to use half the initial dose that we mentioned with calcium. If the patient is on digitalis digoxin, use only 5 ml of calcium gluconate or 2.5 ml of calcium chloride, and your titration is also half of the dose to avoid cardiac toxicity. Finally, after you stabilize your patient and you started measures which cause redistribution of the potassium or removal of potassium from the body, it's better to recheck the oral potassium intake, restrict it. Your dietitian or nutritionist will restrict oral intake the oral intake of the patient to less than 2 grams per day. Avoid intravenous potassium. You have to avoid intravenous potassium fluids and any medication that may cause hyperkalemia, as ACE inhibitors, ARBs, spironolactone nonsteroidals. If potassium hyperkalemia persists, it's important to review again the diet and the compliance of the patient. Check the drug chart. Check GIT bleeding or occultive bleeding. Exclude that there is a tissue destruction and compartment syndrome. And finally, review your dialysis access and dialysis adequacy. I have to mention that in this lecture, we are discussing only the management of acute hyperkalemia. But management of hyperkalemia in general and diagnosis of hyperkalemia in situations rather than acute kidney injury or chronic kidney disease will be mentioned in details in our online webinar discussions of the electrolyte chapter when we discuss the potassium disturbance. But now we are discussing only the management of acute hyperkalemia in acute kidney injury. One of the most important points that may cause acute kidney injury that may cause hyperkalemia in acute kidney injury patients or even end-stage renal disease are blood transfusion. Blood transfusion may cause hyperkalemia and volume overload in our patients, so it is better to avoid blood transfusions away from dialysis sessions. It's better that transfusions are safest given during the dialysis treatment to avoid its hyperkalemic effect and its volume overload. Thank you for your watching to the lecture. Again, you can find this PowerPoint and other PowerPoints on efforttube.com. The videos, all videos of our lectures are on our YouTube channel, EffortTube, and check our Facebook group for daily MCQs and online exams after each chapter that we finish. Thank you and see you later in next lecture.